Hello, good evening, Hafiz. Can you hear me?
Yes, sir, we can hear you. Good evening.
Oh, great. Okay, I think we'll just try to give some 5-10 minutes for others to come
Yes,
in
good evening,
before we
sir.
comment.
Okay.
As the anchor of the program, Dr. Hafiz, do we give 5 or 10 minutes for other participants to come in?
Yes, let's give 5 minutes, sir.
5 minutes, okay.
Yes.
So after 5 minutes, we can start.
Yes, we can start. Well done, sir.
Okay. Okay, good evening, colleagues. Shall we
Good
start?
evening, sir.
5 minutes after 8, as we have agreed, we should start by 5 minutes past 8. Well, as a way of introduction, let me just show off my face for those who have not met before. And then after that, we can put off the video to ensure smooth running of the program. My name is Bashir Bello, a professor of physiotherapy, presently at Bible University, Kano. I will be anchoring the program for this evening. We're going to be looking at health ethics as regard physiotherapy perspective. So permit me to share my slide while I put off the video. Thank you. Thank you. Yeah. Okay. Can we see the slide? Is it clear?
You did the class. Was they waste money up on that?
Colleagues, can we see the slide?
Yeah.
Sorry, can we see the slide?
Yes, sir. We can see.
You don't join. Yes.
Oh, well, it's just for us to interact for the moment, and then just be sure we're on the same page. So this evening we'll be looking at ethics in healthcare, of course, from a perspective of a physiotherapist. So for this evening, our workshop agenda. Sorry, can we just mute our phones? Sorry, the speakers. Excuse me. Let's put our speakers on mute so that we don't disturb the class. Yeah, so the agenda for this evening will include an introduction to ethics in healthcare, and then we talk about ethical principles in physiotherapy. Then we're going to look at some case studies, and then we're going to do group discussion. So it has to be very, very interactive. We're going to interact to see how we can, overcome some ethical dilemmas in our practice of physiotherapy. So we want to group the class as we move. Of course, we're going to talk about, and then we're going to look at ethical decision-making framework. How do we make decisions that have to be ethical? We're going to see scenarios that will have to come, and then see natural processes, and then you will see some ethical situation. What do you do at that moment? So we'll see what are the framework, because your decision has to be based on your hypocritical oath that you not discriminate within your patient. And then every patient has a right. You're going to see all those rights as we move. And then you come through some dilemmas in which you must have to make a decision. I give you an example. There is a faith in Nigeria. You call them the Jehovah Witness. They don't accept blood transfusion. Now, if a patient is dying and the patient needed blood, but she's from this faith, what do you do as a doctor? As a physio, do you allow the patient to die because their faith doesn't accept that transfusion, which is the most ethical thing to do? So those are dilemmas that we're going to see as we move. And lastly, we want to have some question and answer session, and then we'll wrap it up for the night. All right. So as a way of introduction, we're going to start by talking about what is ethics. You know, the whole world is based on some ethical principles. all these religious rules, the laws are based on ethics. So what is ethics? You know, because the question is, why are we being governed by some laws, some constitutions? You know, so it just to make everybody have a right to know. So the creator will send you the manual telling you what is the difference between good and bad, what is the difference between right and wrong. So you must have to know all these, and then that's what will be guiding you. So we call those things ethical principle. So as a way of definition, we say ethics refers to the principles that govern behavior, focusing on what is good or bad, right or wrong. So it means, is it human beings that come up with ethics, or no, is the creator that is the first. Sorry about that. It seems we lost our connectivity at a point. I'm just going to go back to share my slide. Yes. So it was just at the beginning, and I was trying to define what is ethics. If you can hear me, I said ethics refers to the principles that govern behavior, focusing on what is good or bad, right or wrong. So we need to know in our practice of physiotherapy, what are the things that we do? What behavior do we depict that seems to be good? And what are the behaviors that you will show that will tell you, no, this is a bad behavior? So those things are what we call ethics. I said ethical practices build trust between the healthcare provider, that is the physiotherapist, and his or her patients. So if there is this ethical practices, what the first thing it's going to do is that it builds this trust between you as a physiotherapist and the patient you are being treated. I said ethical practices help us to guide healthcare professional to provide high quality care. That is, if there is ethical principle, that principle is what is telling you to do the best thing within the available resources and capacity that you have, you know? So it is this that makes you a professional, that ethical principle that you follow. I said ethics ensure that the patient rights are respected. Of course, you should know that, in our scenario in Nigeria, you always see yourself as the doctor or the physio, as if you are the one that is helping the patient. But of course, for those who are in private practices, that is not the case. It is when you go to our government hospital that you'll be begging a doctor or whatever. But if you run a private practice, if you don't see your patient, if patient don't come, how do you even make the money? So it means you respect your patient, you value them, okay? Because whatever you want to do to them, you don't see as if you are doing them a favor. You see it as their rights because they pay for it. And of course, when you walk outside Nigeria, you realize that the patient is the greatest stakeholder in any health practice. Because if the patient is not there, then there is no point of being a professional in that field. Now, I said ethics ensure, or ethical principles promote fairness, of course, in the distribution of healthcare resources. It is your ethical principle that will let you to know that, okay, this is the best thing to do for the situation that you have. So you need to have all these principles to know what is the best to do at this point in time. And I said ethical practices uphold the integrity of the professional, because as a professional, There are things when your patient see you do, okay, the first thing is that the patient loses confidence in you. So it means you must uphold to the high standard of ethical principles for you to have integrity, Therefore, this will help you to foster a culture of honesty, accountability, and transparency. I don't know how you as a professional, and then a patient will see that you're trying to swag him of his hard-earned money. You're being corny, or a patient should accuse you of theft. I mean, that is the highest of every type of loss of integrity that they will find in a professional. So ethical principle will help you to uphold your integrity of as a professional. So we look at usually ethical principles, what it helps us to do to ensure that everyone who seeks the services of a physiotherapist has the right to service. It means irrespective of whatever denomination you come from, region of the country, your ethnicity, your nationality or religion, as long as the person needed the service of a physiotherapist, you're not going to come up with, okay, this guy is not in our political party, let me treat him the way he will not feel better. Or this person is an elderly man, let me just do him so that he will pass on. So no, you can't do that. Because why? Your ethical principles as endowed in you that from the hypocritical oath you took from the one in joining that profession, you have sworn an oath that you're going to give out the service of physiotherapy to everyone, regardless of their age, gender, race, nationality, religion, or political affiliation. So all these are things we must pay attention to. According to the WCPT, the World Physiotherapy in 2020, they mentioned that for everyone who seeks services of a physiotherapy, that person has the right to service, regardless of their age, gender, as well as the mentioned ethnic origin, creed, color, sexual orientation. You can imagine, I know most of us in Nigeria here, when you see that someone is bisexual or somebody is a lesbian or a gay person, you feel irritated, you wouldn't want to treat, but your principle of ethics should not stop you, should not allow you from not treating such a person. So this is something that we have to put at the back of our mind. Because of your ethical principles, we must not discriminate between an individual in rendering physiotherapy services. I said, lastly, ethics provide a framework for professional conduct. It helps you as a physiotherapist navigate complex situations and make decisions that align with moral and professional standards. So whenever you look at it from a morality point of view, you see that that thing is ethical. And when you look at professional standard, we see that whatever you have done is also standard. Now, let's look at the core ethical principles that we'll see in physiotherapy or other healthcare generally. The first ethical principle is the principle of autonomy. Autonomy.
Sorry, Prof.
Yes. Hello, did you bring some money? Sorry, is it that some people cannot hear me?
The participant in the YouTube, if you can help put in a slideshow, they can. No, the slide cannot be, it's just visible on YouTube. If you can put it in a slideshow.
Okay, I should put it on slideshow.
Presentation. Yes.
Okay, fine. I think it can go this way. Is it good like this? I said the first principle of the core ethical principle, the first one we'll be discussing is the principle of autonomy. That is, and autonomy means the patient has the right to make their own decisions. For instance, the patient can come to you and you as a professional you have evaluated the patient, and then you say this patient has maybe low back pain, and the patient will require short-wave diatemy, exercise, or TENS. But the patient tells you, no, I don't want TENS. No, I don't want this or that. So it is the right of the patient, which you as a professional must respect, that since the patient will not want TENS, even though TENS is recommended for the treatment of this problem, but the patient says, I don't want it. So what will you do? Will you now say, no, this is what I must do for you, or you're going to respect that right of the patient? So these are some dilemma we're going to be looking at. How do we balance between professional boundary as well as the autonomy or the rights of the patient? So what I said, autonomy means you as a professional has to respect the patient's right to make their own decisions. So what it means again is whatever you want to do for a patient, you must give them the most appropriate information to make their decision. Because decisions we're talking about should be informed by adequate and important information. For instance, you want the patient to undergo, say, use of TENS, then you must pass the information. What does TENS do? What are the likely advantages? What are the disadvantages? What are the effects? What are the adverse effects? What are the positive effects? So all this information must go to the patient, and then you must not allow the patient to make their decision after they are well informed. And of course, whatever decision they make must be respected. So that's autonomy. Another principle is the principle of beneficence. That is, beneficence means acting in the best interest of the patient. That is, whatever you're doing is all for the purpose of the patient to get well, or that would what you're doing is what is in the best interest for that patient. It means the patient is going to benefit in everything. If it's not beneficial to the patient, then that thing is not important. For instance, you're trying to use a new say equipment or a new intervention, and all you're trying to do is for a documentation purpose or for research purpose. You want to publish whether this thing is using or not. Now, if as long as that thing you know is not going to help the patient, it's just for your own research purpose, also for your own benefit, then that thing should not be used on a patient. Do we understand that? So it must be on the best interest of the patient that you're using. That's why it's ethical. You remember the case of Pfizer in Kano, when a company, Pfizer, prepared a drug that have not been tested in any other population, and they brought it to Kano for treatment of spinal meningitis or cerebral meningitis, and that now led to some consequences that led to death of one patient. The people that brought that drug knew that it's likely going to create some harm, but they are only interested in doing what? Identifying the effect. So they did not disclose many of those things that they know until many of our patients started dying. And then they raised the issue and they realized that they did not even pass through ethical committees. So these are some issues that we have to understand, that the company that is preparing the drug is more interested in the money they want to make than helping the patient. So whatever you're doing must be in the best interest of the patient. Another principle is the principle of non-maleficence. That is, do no harm. Whatever you're going to do should not add more to the problem of the patient. In fact, it's better to tell the patient, I'm sorry, I cannot help you. I don't have the capacity. I don't have the expertise. For instance, you bring a patient to me with maybe a neuro case, and I'm a sport and orthopedic physiotherapist. There's nothing wrong that I don't have the expertise to handle this case. I would rather refer you or ask you to see someone. It's better than for me to say, okay, no, this patient is from the governor. If I treat the patient, I'm going to make more money. And I know I cannot do that treatment. So that thing, if you do any treatment without you having the expertise, you don't have the necessary qualification to do that, and it led to harm on that patient, then you have lost what you call your professional ethics, because you didn't do it to the best interest of the patient. You were doing it for some ulterior motives or some things you want to gain, and that led to harming the patient. So that's a big problem, and that could lead to you losing your license to practice. Of course, you also have another principle that we call the principle of justice. This principle is what ensures fairness and equitable treatment. We all see this happening in front of our eyes. And most times in our public hospitals, our treatment ward, you see that if you are used to a patient, maybe somebody, a patient that are highly placed, the patient came into this clinic today, you met, you treated the patient fine, and then the patient was leaving, and just to appreciate what you did, and the patient gave you something very meaningful, assuming the patient was leaving and he transferred 100K or 200,000 to your account. The moment you see the patient next, is that people are waiting on the queue. But because you know that this person, there is something you're going to benefit from the patient, and you jump up to the line or you join the queue just to treat the patient, then you know you have not been fair. And that is a very, very bad conduct of a professional, because you're not trying to make justice and equitable treatment among every person. The same thing applies that, okay, this patient, for some benefit or for something you are getting from the patient, you're able to go ensure that if it's a shortwave diatomy and can only use for 1 or 2 persons in a day, you have gone to lock up the room until you use it for that patient. No any other person can use it, even though they may need it more than that person. So all these are not ethical principles that we should encourage. We should try to discourage such practices in our clinics. Of course, we also have the principle of fidelity. It is how you are able to maintain the confidentiality and trust between you and your patient. Assuming you are treating a patient who is HIV positive. Of course, nobody knows the patient is HIV positive, but you and the patient. And then the moment you finish the treatment, you go outside or you go to back home. I met a patient today with HIV. I mean, and the patient somewhere gets to know that you are the one that said that. I can lock you up. You remember the case of Prince Charles of the UK, where a medical doctor who assessed him and reviewed his file now released an information that King Charles has a prostate, So he could not maintain his confidentiality. That led to losing of the license to practice of that doctor. So we must understand that these are principles. You maintain the trust and confidentiality that is reposed in you. And of course, we have another principle that we call the principle of veracity. That is, you have that commitment to honesty and telling the truth, irrespective of whether it pays you or not. So these are principles, are the core ethical principles that we'll be looking at in this presentation. Now let's go to the first one, which is principle of autonomy. I say this is about respecting the patient's right to make decisions. Excuse me. So I said autonomy refers to the right of patients to make informed decisions about their condition. I said it is based on the principle of self-determination and respect for individuals' capacity, for choices. So all these are issues that you need to understand, that your patient also have the right to make their own choice. I gave you an example earlier. So please, you may not say, no, I am the doctor, I'm the one who knows what is wrong with you, I'm the one that will tell you. No, you must have to give the patient full information. You will see this autonomy is usually not being respected in many of our colleagues, especially when you working in a team. The orthopedic surgeon, the neurosurgeon, they may be the first contact to meet a patient. Let's assume a patient with a chronic low back pain goes to them. Now, these patients, the moment the surgeon realizes that the patient is very well to do, could afford a surgical procedure, the surgeon is not likely to tell the patient about alternative treatment. They will only continue to discuss and show the patient surgery is just the only treatment that can help the back problem. In so doing, the surgeon is not likely to give the patient any strong painkiller that will reduce the pain, because the patient knows that if the pain goes down, the decision to do surgery will not be there. So the surgeon will not give any strong thing. They will just give you Panadol or paracetamol and tell you, well, we have to just do this surgery looking at your MRI. Now they know that there are other alternatives, but they're not going to share it. They only give those patients the information, and that's the only choice the patient can make decision out from. So with so doing, most time this is a half information in which the patient cannot make any informed decision out of all the discussion he has with such type of professional. So therefore, I said we must ensure that patients have all the necessary information to make an informed decision about their treatment. I say information should include the nature of the treatment, potential risks and benefits of that treatment. Like I mentioned earlier, you want to do a surgery, you just tell the patient, look, there is a compression in your back. All we need to do is to just go and decompress, and then you are good to go. Nobody is telling the patient, no, we can go and try to do that decompression, and then we can test the nerve, and then you may not be able to walk again. They know if they make all those kind of information, the patient will not accept for the surgery. Of course, they will not give the patient information about alternative treatment. And of course, they will not talk about the consequences of refusing the surgery or the other treatment they're talking about. So all these are the information that patients should be given freely. And I said the consent should be given voluntarily without coercion or undue influence. Like I said, the patient can have enough money for surgery without any big problem. So that we must not try to influence the patient unduly. Look, if you just do this surgery, tomorrow your pain is gone and there's nothing coming back. Now, if you don't do this by tomorrow, you are likely, I have met many patients that will tell you, doctor say, if I don't do this surgery, next 1 or 2 weeks, you will stop working. You've created fear in the heart of the patient, and you find out that the patient will not be able to do any decision than to accept what you have said. Now, let's take a case scenario about the principle of autonomy so that we can see how does it play out, okay? I present you to a case of Mrs. Smith, a 65-year-old woman who has been experiencing chronic knee pain due to OA. She has been under the care of her physiotherapist. The physiotherapist is Dr. JJ or PTJJ, put him in that case for the past 6 months. Despite conservative treatment, including physical therapy, exercises, pain management strategies, and lifestyle modification, Mrs. Smith's pain has significantly increased. You can imagine, she had gone through all this, but her pain is increasing. And this is affecting her mobility and quality of life. The physiotherapists recommend a more intensive treatment approach involving intra-articular corticosteroid injections to reduce inflammation and alleviate the pain. You can imagine the physiotherapist is the one that is recommending. I'm not saying the physiotherapist is the one that is trying to administer. He's just saying maybe we should go for that before we continue. He explained the procedure, its benefit, potential risks, alternative options, ensuring that Mrs. Smith understands the information provided. please let's put an underline on this part. That patient must understand the information you are providing. You can provide information and the patient may not understand. And you know how we do, or maybe in hospitals or doctors, they're just like, no, I've told her. And you know that quite well the patient does not understand what you have said. Most time we will use all those big medical jargons to talk, and the patient will just get confused the more. All you just understand that you want to do a steroid injection. Because if you tell the patient want to give you a corticosteroid injection, what is a corticosteroid injection? You know, you have to explain all those things, and you must be sure that the patient understands the information that they provided. Considering this case, I said, after careful consideration, Mrs. Smith declined the recommended corticosteroid injection. She expresses her concerns about potential side effects, such as the risk of infection and the temporary nature of the relief. Mrs. Smith also shares her preference for non-invasive treatment and her desire to explore alternative therapies such as acupuncture and dietary supplements. Now, I want us to discuss what are the ethical considerations in what the discussion between the physiotherapist and Mrs. Smith are undergone. Please, you can open up your features. I want somebody to tell me where is the principle of autonomy here? What is it that, what are the real information that this physiotherapist has passed to this patient for her to make a decision? Yes. I told us we're going to have to be interactive. So please, you can feel free to speak. Yes, any person who wants to say something can just open up their mic. Please feel free to speak. You can identify by raising your hand or something. Hope you can hear me, guys.
We can hear you, sir.
Yes, please. So, Mr. Udi, you want to tell me something about the consent and autonomy this patient has? I need somebody to just give us some understanding of what we have been saying as regards informed consent as well as autonomy. Where do we see it in the case I've presented? Should I go back to the case? Yes. Any individual who wants to contribute, please just feel free. We just want to have an idea. Are we moving together?
Good evening, sir.
Yes, good evening, Tioma. You're welcome. Yes.
Okay, sir. If I understood what was being explained, the autonomy the patients had here is that the next step the physiotherapist wanted to take, he did not impose on the patient. He did not introduce it as just a next session. In next session, we are going to do this, pay a certain amount of money for this injection that will solve your problem. He actually explained to her what was going to be done for her to be able to make her decision.
Perfect. So what are those information he gave her now? Can you just pick 2, 3 of those information he talked about?
He explained the procedure, he explained the benefits, he explained the potential risk. He even gave her the alternative options, and he also made sure that she understood.
She understood.
before
So perfectly, these are the
she
kind
had
of
to make it.
information we're talking about. That the physiotherapist must be able to give whatever he's recommending as a treatment. Then she'll be able to talk about how does this treatment go. That is, it talks about the procedure, you know, and then its benefits, the potential risks, Now, if we're not doing this, are there other alternatives? You have to give to the patient, and then you have to be sure the patient understood all those things. And that is why we talked about Mrs. Smith until after careful consideration of all this information she has said, or the therapists have given her, she now declined the recommended treatment of that corticosteroid injection. Now, she has the right, to decline the treatment. Yes, any person?
Yes, Prof.
Yes, sir.
She has the right. As good as the procedure is, and as good as the physiotherapist had explained the benefits to the patient is the owner of her own body, and she has the right to decide whether to follow whatever the physiotherapist has said or not, even though the benefits have been explained to her clearly. So the therapist will also need the patient's consent. It is when the patient gives her full consent that the physician and embark on the procedure on her. If she does not give her full consent, no matter how good, no matter how nice the procedure is, and no matter how much benefit she stands to benefit from the procedure, she has the final say as regards whether she will accept the procedure or not. So the physiotherapist must be sure that the patient had given her consent before he can go ahead. Otherwise, there are medical legal challenges that the physiotherapist will face if it goes ahead. Thank you, sir.
Thank you very much. That is the issues we're trying to discuss here tonight. Now, I want to put it up to you guys. Just take yourself, you are the physiotherapist. Don't forget that you have been giving this patient every type of physiotherapy treatment, shortwave, everything. And then you've been doing all the exercises that you're supposed to do. You have been managing this patient using all physical therapy modalities. But they say the pain of this patient has significantly increased. Now, you talked about this injection as one of the things that will reduce the pain. And the patient now declined that. As a physiotherapist, are you supposed to feel worried, disturbed, and then how do you feel about this patient? How do you feel about the patient? Yes, please. No person, please, let's interact.
Good evening, sir. Good evening, everyone.
Thank you very much, Dr. Alfred Silas. Go ahead.
Actually, this patient, personally, I'm going to feel disturbed for this patient because looking at the situation, after all my trying all I know I can do, and the patient is still not getting better, I think personally, it's either I refer her to somebody with more experience, or maybe I make more research or not, but I'll be seriously disturbed.
Yes, I'm trying to look at how do you accept or control that principle of autonomy. Because if you accept that she has a right to either decline or accept a treatment, and this time she declined, are you supposed to be worried, or you're supposed to like the patient the more? What that's the feeling I want us to talk about tonight. What do you do with such patients?
Hello, sir. I think because you are concerned about the patient's condition, you still have to go ahead and explain further what other procedure you think you might be able to use to also be able to convince the patient that you have to explore other avenues that you can also use to achieve the result that you want, since she has declined that which you have been using for her and the pain is still increasing. So you might want to explore other procedure. You might want to discuss with her and see how you can improve her confidence in other procedures that can also give her relief, apart from using what you have just done that didn't give you the result that you desired.
Exactly.
Thank you, sir.
Thank you very much. Well, at this point, I want us to know that what it means to respect the patient's autonomy, is that you should not feel worried that she has declined the recommended treatment. Rather, it should give you an opportunity to explore why did she decline. She mentioned that she's talked about the potential side effects, that she's scared. She doesn't want to have infection in her knee. And of course, she has been able to understand that this injection, based on what you have told her, that the pain relief is only temporary. So if she weighs between this and that, then she feels, look, it's not, I'm not comfortable with it. So you must respect that and begin to think out of the box. What else can we do? And then you must like to appreciate the patient, not get angry. Like Silas said, I'm just going to send that to another person. Okay? No, you don't send that out. You try to explore more. So I'm going to share my thoughts with you guys. I said the PTJJ ensures that Mrs. Smith is fully informed for the recommended treatment, risk and benefit, as well as alternative options. The physiotherapist respect Mrs. Smith's decision to decline the recommended treatment, recognizing her right to make choices based on her values and preferences. And of course, the physiotherapy also maintains open and supportive communication. This is where Silas, I said we should do. You must be objective. You accept what she is talking about. Then providing information in a way that is understandable and respectful of Mrs. Smith's concern. So you try to look at, okay, can we now do this? Can we now do that? And I would say the physiotherapy should be able to tailor the treatment plan to align with Mrs. Smith's preferences, ensuring that her values and goals are central to her care. So we must understand that when you are even looking at this is the best treatment for a patient, you must also try to see that treatment, does it align to her value? For instance, I give you a very disturbing or a very cultural something that we have in our own scenario as Nigerians. Take, for instance, as a male physiotherapist, you got a female patient with coccydynia, the coccyx bone, that the pain is deep there, and you need to manipulate that. I mean, you can't just go in to say you want to treat such patients if you know that that's the best treatment. Do you understand? So you need to understand what her values, her goals are central to the treatment. For instance, she's a married woman. I mean, there are many of our cultures that does not allow a man to come close to a female, not to come going deep down. You understand? So you must align whatever treatment you're doing with the value of the patient. So that's for the first issue of autonomy. Let's look at beneficence. I said the principle of beneficence means an ethical principle that refers to the obligation to act for the benefit of others. So whatever you're doing is not for your own sake. Let it not be for your research. Let it not be for your own pocket. Let it be about, because let me give you a simple example here. It is some of our unethical principles in physiotherapy. The moment the patient comes in with OA that we're talking about, even though the patient does not need a rigid knee brace, we are of that kind of opinion. I will buy a knee. Why? Because you are the one selling me. It's not because the patient needed it as much, but you know that the patient has the money. The patient will quickly jump to buy it, and then maybe the rebate, or maybe there's some percentage come back to you will now you prescribe it for the patient to go and buy, or to buy it from you. You're saying that that treatment was not for the benefit of the patient, most often is for your own personal benefit. And that means it is unethical. We shouldn't do that. I said beneficence means promoting the well-being and taking actions that contribute to their health and happiness. It's about the patient. It's not about you. It should be about the patient. Therefore, physiotherapists must prioritize the well-being of patients, aiming to improve their health outcomes through effective treatment and compassionate care. What I mean by compassionate care, sometimes you need to put yourself in their shoes. A patient going through pain, worries, and all that, and then you as the physiotherapist just calling the patient because okay, the queue has been too much. Madam, we have been calling you since when you didn't even come. Oh, you're not answering. I mean, there's no any compassion in the treatment you are giving. Sometimes the compassion will give the patient, or more wellness than the treatment you are giving. So please, we should show some compassion as we interact and treat with our patients. I said, principle of beneficence involve both preventing harm and actively promoting good by enhancing patients' physical, mental, and emotional well-being. So all these are the principle of beneficence. I said, in summary, beneficence means you should be acting in the best interest of the patient. You should prioritize the patient's well-being in all decisions. Everything you want to do is about what is going to help the patient most. And of course, you must learn how to balance benefits and risk. You know, we talked about Mrs. Smith when we're saying she needed to have an injection. And that injection, one of the risks is about what? Is about infection, risk of infection. And of course, one of the benefits is that it's going to reduce pain for a short time. So you now see, when you balance this, which one do you tilt to? So you always look at the patient, not what you are going to get. Imagine trying to tilt to the injection, considerably, just because the patient is going to pay the amount of that thing into your pocket. I think that would be very, very unethical for any person to do that. Therefore, you should be able to evaluate the potential positive outcome versus the possible adverse effect. So that means it's about what benefits the patient most that you're going to tilt to. Now, let's look at a case scenario also about principle of beneficence. In this case, I present to you Mr. James, a 55-year-old man who has been presenting to physiotherapy clinic with chronic low back pain that has been affecting his daily activities and work life for the past year. Mr. James works as an office manager. Of course, he leads a sedentary lifestyle and has a history of hypertension and mild obesity. Mr. James' doctor has recommended physiotherapy as part of a comprehensive management plan. And Ms. Lee, who is the physiotherapist, conduct a thorough assessment, and she identified the following key issues. That the chronic low back pain of Mr. James is likely due to poor posture, muscle imbalance, and a sedentary lifestyle. And the risk factors that would have led to this is Mr. James' overall health, including his hypertension, obesity, which may affect his treatment and recovery. Now, what are the issues that we're going to be looking here out for when we're trying to use the principle of beneficence in managing Mr. James? Yes, any person. What are the issues that should be of concern to us when we're trying to look at the principle of beneficence in managing Mr. James? Yes, please. Yes, feel free. Feel free to talk. Just unmute yourself. Yes. Let's get it quickly. I just want to have to know what is it we're understanding about these things, because we do find them every day in our clinics, but because we don't pay attention, we really do not know that these are the things we do. But of course, we do them. Yes, please. A volunteer. Hello, who is there?
So I didn't get the question. Please repeat the question.
Yes, Mr. Alfred, go ahead.
Sir, please repeat the question. I didn't get the question clear, sir.
I'm saying, looking at the case of Mr. James, that Mr. James is having chronic low back pain, and then this low back pain we say is likely due to his job as office worker who is always sedentary in his lifestyle. And of course, some of his risk factors contributed to his low back pain will have been his hypertension status, as well as the mild obesity that he's having. I said, now, if we want to treat Mr. James, in treating him, what do you think should be our principle of beneficence that we should be taking into consideration for Mr. James? Yes, are we there? Okay, let me share what I would earlier. Yes, please go ahead.
Yes, having explained to the patient the needs for what you are going to do, the patient has some underlying problems that you have already been able to ascertain. So you explain to the patient the benefits of the procedure that you're going to give, and also discuss with the patient what are the likely chances that the underlying problem he has will influence his recovery. And you explain to him the need for him to have some modification in his lifestyle because of the underlying problem that he has already that might affect his having his low back pain. So you have to put all of this into consideration while you are managing the patient, so that at the end, the patient will get the benefit of whatever you are trying to administer to the patient as a therapeutic procedure, so that the maximum benefit the patient can achieve. Because you will not just go ahead and treat the low back pain without explaining the implication of the other issues that the patient has. So the influence of the hypertension and the poor sitting habit that he has also has an influence on the back pain that he has. So all of these things has to be brought to bear while managing the patient, so that you now have a proper holistic treatment for the patient. At the end, the patient will have the maximum benefit, and will likely be very happy that you have done all of this for him, and he will follow whatever you have decided to do for him appropriately, sir.
Thank you very, very, very much. This is quite fascinating. I'm happy that we are picking it up. Because all what we have mentioned about this case is that the patient has chronic low back pain. So if it happens to just thinking only about chronic low back pain, it means we are not really acting in the best interest of this patient. We all know that his hypertension could be one of the things that is causing this, his type of lifestyle, the obesity, all these need management. So we must give him a holistic approach. We are managing him as a person in total, not managing only chronic low back pain. And that is what Dr. Udi just told us now. And I think I'm very, very happy that we are catching it. Let's look at what I dropped there. I said the treatment plan for Mr. James should aim to promote his overall well-being, addressing both his back and then the broader health issues, like the earlier speaker has mentioned. I said we must ensure that the treatment does not cause harm. Don't forget he's hypertensive. So you don't put him on any kind of strenuous exercises that may now cause more problem to his heart. Okay? You know you want to do exercise, you know you want to make him active, but you must be very considerate so that you don't put him under any unnecessary situation. Of course, we must also respect Mr. James' preferences. What are the kind of activities he would like? What are the kind of activities that he wants to be involved? You know, is it walking? Would he like cycling? Would he like swimming? So we must also respect him. What it means is we must involve Mr. James in making any decision. All we know that we want to make you as active as possible. But what kind of activity would he like should be part of what we'll be talking about? And of course, we also need to understand that looking at his obesity, hypertension, we need to work with other healthcare professionals so that we can provide a comprehensive care that will address all aspects. Talking about nutrition or the dietitian, that will talk about his dieting to reduce the obesity, talking about seeing a cardiologist that will be looking at his hypertension situation, and other team members that will be involved. So I think it's a holistic approach, which you can see you're going out of your way as a physiotherapist to ensure that you link Mr. James to a cardiologist, you link Mr. James with a dietitian, you link Mr. James with all those who are supposed to work. So this is when everything you're doing there is all about for the benefit or to the best interest of that man. I think we all understand the principle of beneficence in this case. Are we happy with this? Can we move forward?
Yes, sir.
Yes, sir. But sir, there's a question, sir.
Yes, go ahead.
I once worked in a facility, a government facility, and virtually everybody that is coming to that clinic must own an electrode, either for EMS or for TENS, whether or not it's even personally I feel some of them don't even need it, but because the person in charge of the clinic is the one supplying, so almost everybody has to purchase TENS. So does it mean this principle of beneficence is being breached, or is it another one separate?
Absolutely, Dr. Alfred, absolutely. Because in fact, this is the first time I'm hearing. We all know when we have gone through physiotherapy practice, clinical postings, and all that. We have never seen where every physiotherapist must need a TENS machine. Have we seen that scenario before? Now he made it work that because he's the one selling it. I mean, so that's quite unprofessional. It's quite unprofessional. And that's principle, they have breached the principle of beneficence. They have breached the principle of autonomy. The patient might tell you, I don't want TENS, but you say you must buy the TENS electrode. So that's quite regrettable. But of course, as we learn, we get to ensure that wherever we find ourselves, we try to bring change, positive change as much as possible. That's the essence of the continuous basic medical education. I believe if you had gone through courses like this before you were at that point, you would have raised the issue of ethical, professional ethics or ethical principles for the management to take a look at it. Yes. Thank you. So let's look at another principle of non-maleficence. And this is the principle that I always say, do no harm. It's a golden rule in physiotherapy. Do no harm. That is, if you cannot help the patient, please don't add more to their problem. Is it not better that you just tell the patient, sorry, I cannot handle this, So you do no harm. And this is when you show commitment to avoid harming the patient, So anything you do that you're trying to avoid harming the patient, like the scenario Dr. Silas just talked about, that we're now enforcing purchase of electrode. If one of those patients is coming from a typical village and does not have money for electrode, must you now force them to do that? It's also a type of harm to the patient. Okay? So we must try as much as possible to identify and mitigate potential harms. For instance, if the pathway or the corridor the patient will walk through to get to your cubicle is not well lighting, or is slippery, already there is a potential risk for fall in that your clinic. So you must be able to identify what are the things that are likely going to lead to harm in this place or within your equipment. Sometimes you can have loose cables, sometimes the electrodes are faulty, sometimes the manipulation technique you want to use, you don't even know it, and you want to use it. So all those are potential risks for harm. So we should be able to identify, and then we remove anything that will cause harm in that clinic. And so we should be able to assess and address potential risks in treatment plan. When you plan your treatment, and then you see that, okay, this patient, I want to do a HVA, that is a high velocity amplitude manipulation. But do I have that expertise? Am I sure I can handle it? So you should be able to see when you maybe an intern, now put that in a treatment plan, and you as the supervising physiotherapist saw that. You must be able to know that this is going to cause a risk, and then you squash it from the treatment plan. So let's look at the case example, and we'll have to adjust the treatment to prevent aggravating a patient's condition. I'm going to bring up this as we move, but I just mentioned what it means that if you come up as a supervising physiotherapist, you see a younger physiotherapist that he made a treatment plan and he has added some of those treatment that is likely going to lead to burns. For instance, somebody is going to do shortwave diatemy to the knee for 1 hour, that's likely going to lead to burns. So you need to remove it. So these are the issues I'm talking about. So we also look at the principle of justice. Under these, we talk about fair and equitable treatment. Everybody should be having access, to receive fair care, ensuring that all patients receive fair access to care. And of course, it should be about distributive justice in healthcare resources. Here, we're trying to look at, okay, if, for instance, you are the head of department in physiotherapy, now the head of department, say, is controlling 20 physiotherapists in his department. And now the work of patients are more, for instance, the stroke patient. Say you have 70% stroke patients in your facility. Now, in trying to be just in healthcare resources, we'll find out that most of what the budget of the hospital should come in Department of Therapy should be also channeled towards where you have the highest number of patients that will need those things. Do you understand? For instance, they give 5 million naira to physiotherapy department as a budget for the year. And then 70% of our patients are all in neuro. Now, what would be the justification if the HOD uses the 5 million naira to buy only one shot with that? Do you think most of the patients in neuro for the stroke patient will be needing the shot with that? They're not likely to be needing them. So you see that there was no justice in the healthcare resource allocation or distribution. So, and I said the allocation of resources should be fair, not among only the physiotherapists, even among the patients. So we need to see the resources that is there to be used by the patient. For instance, for patient, you want to use 5 cubicles for those with stroke, and then 2 cubicles for those who are orthopedics. And now you now have a patient for orthopedics who their own is only 2 cubicles, but because you are bringing somebody and you really want the person to just go in, you will now deprive an orthopedic patient who is supposed to go into the cubicle that is meant for and bring someone else. So all these are disparities which you as a professional must try to address, understand, so that everyone should have equal and fair access to care. So also want to see this as we move. I said distributive justice is a fundamental ethical principle in healthcare. It aims to ensure fair and equitable access to medical resources and services. This distributive justice refers to ethical principle concerned with fair and equitable distribution of resources among members of society. What we're saying here is not only among the patient, even among members of society. Now, assuming in your clinic, the Senate president is receiving a treatment in your clinic, will you stop the whole patient, assuming you have 100 patients waiting in that morning, and the what's his name? The Senate president walked into your cubicle and required treatment? Are we going to stop all patients? They will not receive treatment until we finish treating the Senate president? Is that good? Is that normal? Is it okay? What will you do if it's in your own scenario? Yes. Sorry. What are we going to do if it's in our own scenario? Hello, are we there? Yes, I'm listening. What should we do? You have, okay, let me not say the Senate president, let's say the CMD of your hospital requires treatment of back pain and physiotherapy, and it's around 10 in the morning, all your patients are gathering, and then will you stop everybody and treat the CMD before any other person will go in? Do you think that is correct? You're just in allocation of resources? Is that the right thing to do?
What you do, hello, sir. What you do, since the CMD is a VIP, you
Yes.
explain to the CMD the pressure that you are presently under and the need for you to see other patients. Then you politely reschedule his treatment and shift his own treatment further so that you can be able to attend to other patients that are waiting before you now make up time to see the CMD much later after you have finished seeing the ones that were there before he came. Since you're not going to give him that's the if you bypass the patients that were waiting and you now go and treat the CMD because of his position, it might look very odd when the other patients are seeing you treating because it will be as if they are of no relevance because you have selectively chosen the CMD ahead of them. So what you will now do in that scenario is to discuss with the CMD that you are still going to see him, but you can now reschedule his own treatment for a later time in that day so that you are able to see the other patient that had already come before he came so that there is no breach of protocol. I think that's how you can handle it so that both sides will feel satisfied that you did not overlook the patients that were there before the CMD and you did not just go ahead to now treat the CMD to slight the patients that were there before he came. Thank you, sir.
Yes. Thank you very much, Dr. Udi. That is one of the ways to go about it. You see, yes.
Yeah, good evening.
Good evening,
Yes.
Dr. Akande. Go ahead.
Well, as an administrator,
Yes.
as I'm not the HOD, but I'm head of unit, my hospital.
Good.
If I cannot send my CMD back, I
Yes.
thought it's not possible. It's not possible.
Yes.
It's not. We don't have only one cubicle in our hospital now.
Yes.
Now, why will treatment of CMD affect every other patient?
Okay.
No, you not suspend physiotherapy department because of CMD. At the same time, what I'm saying is this, that we could find a way. There is a way we can explain to patients sometimes. They have listening, even staff. Sometimes when we have emergencies that has to do with patient, with staff, supposing somebody has a low back pain, disc lesion while at work, and they brought the patient and is a member of staff. There is nothing bad in telling patients, letting them know that sorry, this person that is coming, we are not taking him over you, but because of emergencies and being a member of staff and some other things, they have listening here. The only thing that is worse is when you use power and you did not talk to them and you did not explain to them. That is totally wrong. As an administrator, it's not possible for me to tell my CMD to go back because I will still go to his office. They will tell me to go back. So there is a place of like, that's my own opinion. There is a way of for CMD to come to my department for treatment. It's a high privilege. There are so many things you will not officially listen to if I get there. But by the time we are having treatment, if allowed, sometimes, depending on the level you have with him, there is a way you politely mention. So he can see some things on ground by himself that will not be patient enough. Say, you mean you don't have this? you mean you did some things that you have been requesting for. For me, we have to balance it up. We need to
Thank
tell
you very much.
patients, we need to tell patients that are waiting. This is my CMD, the one, Olori Okobama, the one that pays everybody here. So they to please, we are not taking him over them, but we should give honor to whom honor is due. What I see that is wrong is to take him in and not telling them. And in as much as he does not carry a banner of CMD on his head, they will think you are taking advantage of them. It's not possible for me to reschedule appointment, my CMD appointment, or send away my patient because I want to attend.
Thank you very much, Dr. Agende. Your point is well noted, and I think it's well understood as well. And I think the problem here is because I mentioned CMD. I was mentioning the Senate president since nobody talked about that.
Good evening, sir. Good evening, sir.
But now when I say CMD, it became something closer to our heart. Anyway, okay,
good evening,
Sharifat is man.
Okay.
Let's take Sharifat.
Good evening, sir.
It's another
Good evening, sir.
public relation on his own.
Yeah, so it's okay, Dr. Agende, I've heard you.
Good evening, sir.
Sharifat.
Good evening,
Sir.
sir. Sir,
Go ahead.
presently,
Good evening, you are welcome.
Dr. Agende, we have heard you. Please mute up. Sharifat, go ahead. You are online
good
now.
evening, sir. Good evening, sir. So presently, we have VIP in most of our physiotherapy clinic. In this scenario, what do? VIP patients.
Yes.
You treat them as they come. You don't have to keep them waiting because they pay more. So what are we going to do in this scenario?
Now, this is a clear...
Good evening, sir.
Okay. Good evening. Who is online? Come on.
Tyler, sir. Alfred.
Okay, Alfred, go ahead.
Okay, sir. My point on my view on this scenario, sir. When I did my internship, it was in a Navy hospital. Yes. And, definitely there are a lot of VIPs coming.
Yes.
In fact,
the hierarchy of the military is there again.
Yes. So there are times a general will come. In fact, a whole cubicle, the cleaners, we have to go and re-clean the place and all these things, But the point I'm trying to make is that if a VIP is coming, he won't just come unannounced. Definitely, he will have announced, I'll be coming. And then the department can make arrangements ahead of time before he comes.
That's
so
fine.
That the patients will not feel this one. So even from the way they see the patients see the department making arrangements, they know somebody is coming. So they won't even feel bad. But if the person just comes unannounced, you don't know, and he just comes and you have to just, like the first speaker said, you have to sir, there are tons of patients. Just give us time to prepare. You can now maybe keep him in the HOD's office or something, and maybe find a way to entertain him before you clear up space and he comes. That's my point of view, sir.
Thank you very much. I think this point is well noted here. But Dr. Jennifer is asking a question. The clinic have treatment pass. And then, of course, and as a VIP, as you come in, taken in and treated. Well, those are dedicated cubicles that is well known to all persons that are using the system. Okay, so if you want to pay for that premium service, then that's fine. But what we're saying here is we should try as much as possible that we should emphasize the fair allocation of medical resources, services, and opportunities to ensure all individuals have access to necessary care. This is the point about justice. I was talking about the Senate president, talking about, the most important persons in the society. And that's why I drip it down to CMD. Now, if the CMD comes in and our cubicle is like our general treatment, we do not have IP side, we do not have anything. And it's like 10 o'clock or 11 in the morning. That's the peak when physiotherapy services are going on. And now all the cubicles are under usage. Now, because this VIP one person comes in and we do not have any special treatment, the question I asked was, are we going to stop every other treatment until we see that person? before we resume with others? And I said, that is very wrong, because that's selective treatment. We want all our patients to know that there's a fair allocation of medical resources, services, and opportunities. And I agree with what Mr. Odi said initially, who said that it's simple. What we need to do is to discuss with the VIP that the clinic is very busy now. Could you go? We can now make another time for that VIP to come in, because we cannot stop all the other procedures because we want to see CMD. The CMD is somebody, CMD's case is so close that he knows the situation, he knows the trouble. The fact that because he came today for the treatment, I will not allow him to come when the place is even busy as well. It's simple to discuss with CMD, sir, we will call your attention when the place is free. And he will understand. Secondly, if it's a scenario whereby we just needed to see that person as an opportunity, like what Mr. Kande said, that is an opportunity and a privilege for us to be treating, say, the emir, say, the king, or the governor come into the cubicle. Of course, it's simple. We just go to the patients, all of them. Good morning. This is the situation today. We're going to be holding on, please. We have an August visitor. We just want to take him in, finish with him, and then we'll continue our normal services. I think this will take care of the problem. So we just need to let them know they have a right to fair allocation of resources, services, and of course, opportunities to ensure everybody has access to the necessary care. That's just about that. Now, let's move forward. I think we're trying to work on this. Said we should be able to ensure that our healthcare resources are allocated based on the need, equity, and fairness. That is, I talked about the need when I said 70% are stroke patients, 30 are also or whatever. If this allocation comes, those with the highest need should be given more resources than others. And of course, the principle about equity. Equity does not mean if I give these people 50, I must give the other side 50. No, equity means every opportunity I give to Mr. A, I should also give to Mr. B. For instance, like we keep saying, the medical doctors, the physiotherapists, we're not asking for equality. That how much you pay that person is how much you pay me. That's equality. That's not what you're asking for. You're asking for equity. What is equity? If you are paying him call duty, I'm also doing call duty, you should pay me my own. If you send this guy for residency program, send me for my own residency. I'm not going to residency to become a surgeon. I'm going to residency to become a professional in my field. Do you understand? So that's equity, not equality. And then we talk about fairness. Fairness means, your ability to treat everybody based on his own merits. So we should not allocate resources on factors such as this guy is in APC, is our PDP member, or no, this is a socioeconomic status, or no, this guy is in Northwest. I mean, all those geographical location or personal connection should not be the factors we look at in sharing allocation. And of course, as professionals, we must promote social justice by addressing health disparities and working towards health equity for all populations. This principle that guide distributive justice that we just mentioned, that we talked about equity, which is about providing care that meets the specific needs of individuals, recognizing that different people have different healthcare needs. So what is needed maybe in the rural area is what we should take to them, not what is not needed. For instance, you want to give a health talk, or maybe you want to treat people with hypertension in the rural area, and then you are going with some sophisticated equipment, which we need electricity and so many things, and they are not there. How do you put that equipment there? Or you take an MRI machine there, who is going to handle it? Who is going to service it? So you must understand that everybody has a priority and then specific needs that you need to do. And of course, we should prioritize resources for those who need medical attention and support them most than those who do not need it. Equality means ensuring equal access to healthcare services for individuals, regardless of background and circumstances. Of course, proportionality, it talked about allocation of resources in proportion to the severity of the condition or the level of need. So it's also all about justice, equity, and fairness. I think there are some challenges in achieving distributive justice. The challenge usually is what? Limited resources. Most times our resources are limited. If you ask me, if you're giving 5 million naira for physiotherapy budget, will you prefer to buy one shortwave diatomy, or you would rather prefer to spread it across all the various units in physiotherapy? If all of us will want to spread it, so that when you buy some exercise equipment, buy some heat therapy, at least the department will look more acceptable than buying only just one shortwave diatomy. I said limited availability of healthcare resources, including staffing, equipment, and facilities, is going to make sometimes you may not be able to distribute your resources properly. Of course, you also have geographical barriers. These are the things I talked about when you compare what are the health services you can provide between the urban and rural areas. You see that there is a geographical barriers. Of course, economic inequality. For instance, if I want somebody to do an MRI for low back pain, an MRI is costing over 100,000 naira. And somebody who you say his minimum wage is 70,000. How do you expect him to be able to do an MRI? You know, so that's already the treatment you want to give is already being impacted. You can't do it because of the economic inequality. Of course, there's some policy and systemic issues. Sometimes the policy in the hospital or where you work or in the country can also strain and impact on what distribution you can do for your resources. Now, let's take a case study, for example, of this distributive justice that we're talking about. I said, we look at during the COVID-19 pandemic. I said, you remember they talked about allocating vaccines to countries. It started that Africans were not even given vaccine at all. They were giving the vaccines to the Europeans, the Caucasians, and all that. When the African peoples begin to bring up their own type of vaccine, it was rejected. So there are a lot of issues that now led to know that there are health disparities, even during pandemics, between high-risk population and then the other people. Now, even when the vaccines now begin to trip into the country, it now became, who are we going to give the vaccine first? Is it the medical personnel, that is those doctors and we working in the hospitals that we're going to be receiving patients only? Are we supposed to get the vaccine to prevent our own self first, or we should give to the patient that are already there? You know, so that also became a dilemma. Of course, we begin to talk about also rural healthcare programs. The federal government came up with initiatives to improve healthcare access in rural areas through mobile clinics, telehealth services, and of course, incentives, so that when you are posted to a rural community, they begin to pay you more. So all these are examples how this justice can be distributed fairly. Health insurance reforms also came up as policies that help to expand healthcare coverage to those who are not even having insurance and to the underinsured population, such as the National Health Insurance Act. So these are some issues. And then the ethical consideration when we have distributive justice is how do you balance the individual need with collective welfare? That is, one person might come, this is what he needs in their own community, but the general community might not need what that person is talking about. So we must also be very vigilant to know that when we are trying to allocate resources, it should be about resource allocation This decision should be transparent and based on ethical principle. What is it the people want? What is it we have appraised? Not what one politician needs to be done. So we must understand this. I say addressing these implicit biases and systemic inequalities that may affect fair distribution of resources. We look at fidelity. Fidelity refers to the principle of being faithful and loyal to commitment and responsibilities. It involves maintaining trust and confidentiality in the patient-physiotherapist relationship. It is the patient-therapist relationship, that confidentiality and trust. That's what fidelity will give you. It encompasses being dependable, trustworthy, and following through on promises made to patients. So, here, do we promise our patient anything? Do we promise our patient something? What is it do we promise our patient? Okay, let me ask you, what type of relationship is allowed between a patient and a therapist? What kind of relationship is allowed professionally?
Professionally, we should be as neutral as we can be, but yet being humane. There should be no strings attached. There should be no unusual attachment to our patients. We should be strictly professional with our patients.
Beautiful. That's just the point. It should, all the relationships should be professional. We should not get a situation, because you are already going to begin to make the patient, what do you call it? When you're using that position, you know, you're already using undue, I mean, I don't even know the right word we should use, because you're just taking advantage of the patient. The patient believes in you, trusted you, and all that, and then you are now using it to heal the patient's emotion. So there should be no any love relationship in between the physiotherapist and his patient or her patient. It should be strictly professional. And when we talk about professionalism, it's just going to be about all what you're talking about is about the condition, the patient, how to take care of the patient. It doesn't mean you cannot discuss home and other things, but it should be something that has to do with relating to the patient. For instance, there is a patient that may come to you and have maybe the major problem is she has a child, or of course a child who is involved in you know, in drugs, and then you're able to take the patient through how they can go through rehabilitation, how she can identify the problems of this patient. And you are trying to discuss something that affects the patient. Your own patient is with you for low back pain, but during the discussion, you begin to see that the patient looks depressed, anxiety, and worried, and you ask for her, and she's able to tell you that this is the situation. She's going through you know, a problem of her child being involved in drugs. So now you move into that, and you're beginning to bring her how she can go for psychiatry, rehabilitation, and all that. It's part of treating your patient. So, but it should not be out of that. Your relationship should not be about another business or something. No, it's strictly professional, and that's what we're talking about. Your patient should have the confidence that they can believe in you, they can depend on you, that you are trustworthy, and you're not going to leak out any information until you. But there's a point here. I said, when you promise the patient, you should be able to fulfill the promises. And I ask the question, do we promise our patients? Do we promise our patients? Hello?
We do not promise our patients. We explain to the patient the outcome of what we're about to do, and we do professionally.
Exactly. So there is no any way you promise that I'm going to treat you and you're going to be 100% fine. No, you don't do that. You don't promise your patient. Okay? So please, let's keep the relationship professional. Now, the importance of fidelity is that, number one, it builds trust. And of course, it helps you to be consistent in your care. when the patient fidelity fosters trust between patient and the therapist, which is essential for effective therapeutic relationship. The patient already have a belief that okay, what you're doing is the right thing, and therefore the patient will be able to follow all your instructions and keep to the treatment. Okay, because if there is no adherence as well as commitment to that treatment, it's likely going to fail. So therefore, the patient needs to trust you to be able to follow all your treatment and guiding principles for that case. Of course, I said if you're consistent, you make sure that you're following all the professional standard and ethical guidance. The patient becomes better in the outcome. And of course, when you follow the trust that is embedded in you, your patient becomes more safer because the patient will know that is being protected, by being vigilant and committed to providing health care, that you know that this is a professional, is being watched and is being guided by his principle of his profession. I said example of fidelity in practice is confidentiality. When a patient gives you an information that is only there to them, and then you go ahead to share with an unauthorized individual, it means you have breached confidentiality. So you must be able to keep that information as much as possible to only you. And of course, reliability. Your patient believes that you are dependable in meeting patient appointment. So you should not ask the patient to come when you are not there. You should not ask the patient, we are going to do 10 treatments, and then after 2 treatments, there is no reason, just decided to cut off the patient. All these are issues we should be able to take care of. And of course, you should be able to advocate for the patient's best interest. Of course, especially when it involves challenging institutional policies and practices. For instance, in your institution, patients will not be treated except they have made their payment. Now, this patient came into you, and then you did not know the patient has not paid. And then the patient came in with severe pain, and you felt, look, it's upon me, I will treat the patient first, and then we'll make the payment later. So all these are things that patients will believe it's all about them you are working for. So we look at veracity, which refers to the principle of truthfulness and honesty. It involves providing accurate, complete information to patients about their health, treatment, and prognosis. Now, this principle of veracity, it's very, very dicey and delicate. Recently, I met a patient, a 75-year-old man, who the patient, the son of the man brought the patient to me as a case of chronic low back pain. Now, this patient had seen a neurosurgeon 2 weeks before they brought the patient to me. Now, when the patient came and I assessed the patient, the MRI the surgeon asked him to do demonstrate little or nothing rather than the changes you see due to degeneration. He's a 75-year-old man, so whatever change you see there is acceptable. Now, the patient is finding it difficult to walk, but the doctor, the neurosurgeon, mentioned that it is due to a compression of the nerve root of the spinal. I looked at the MRI back and forth and all through. It does not demonstrate any compression of the cord. But of course, the reports of MRI will always tell you there's indentation and of course and compression at multiple levels. I looked at all that compression. It's not the reason why this patient is not walking. The next thing I did was to evaluate the patient for prostate as a man. And of course, I was shocked with the result of the prostate. The patient had a PSA of over 4,000. You can imagine that. And I said to the patient's son, I said, did you show this result to the doctor? He said, yes, he saw it. But why is it that the decision of the doctor is that he's going to do a decompression in the lower back of that patient? Ladies and gentlemen, if I should ask you, what is likely to cause the pain in that problem, the pain in the back of that patient? What's the likely cause of the pain and inability to move?
Metastasis has been deposited in the spine.
It's a metastasis. A PSA that is not supposed to go more than 4 units. The standard unit is 4 maximum. Now this patient had 4,000. This is the first time I'm seeing that in a patient. But a neurosurgeon is still saying he wants to do a back surgery. For heaven's sake, what would that do? Do you want to give me an excuse that the surgeon does not really know that information? There's no excuse I could put for that surgeon, because all he wanted was, the son is a very well-to-do person, was ready to pay the 4 million naira he was asking for, but someone guided him that they should see me. Behold, after that day, I assessed the patient. I asked him to go and do another scan of the pelvic scan. Let's see the size of the prostate. You won't believe that night that patient left. When he came back, he called me around 9 p.m. and said, "Oh, Baba can no longer urinate." You see? So I asked him to take him to the urologist, and that is where they now had to do surgery for him and all that. But of course, why would an orthopedic surgeon or neurosurgeon want to do surgery to the back? So it means the person is not giving truthful and honest information. And what he's trying to do was just for his own best benefit, not for the benefit of the patient. So you can see that veracity is breached, beneficence is breached, and maybe maleficence will even come in, because when you cut the back, the guy keeps suffering from that back, and then the trouble is not going well. So I said, in this case, it requires transparency in communication and the avoidance of deceit or misrepresentation, which is likely the situation there. I said, veracity helps us ensure that the patient have all the necessary information to make informed decision about their healthcare. It builds trust and mutual respect between patient and the healthcare provider, and it empowers patients by providing them with truthful information, enabling them to take an active role in their care. I said, example of veracity in practice is when you provide a clear, accurate, and timely information about diagnosis, treatment option, and potential outcomes. Like this patient with the CA prostate. I mean, do you want to tell the patient you're going to cure the prostate? Especially at the point where it has metastasized? You should be able to tell them the truth, but of course in a simple way that they may understand that we're going to manage it. You cannot say you want to cure it at that point, because you have to be honest about if there are medical errors or uncertainties. And of course, you discuss them openly with the patient. Unfortunately, this is where we don't talk about it, especially all these our surgeons that we're talking about in our orthopedics lane. When surgeons make mistakes, they don't come to tell the patient it's a mistake. I have a patient that they went to surgery from L1. They kept making mistakes until they took that patient to C4, C5. The whole spine has been locked up. Of course, because of 1 or 2 mistakes from the surgeons. So please, we should give a truthful information. Of course, we should be able to fully disclose all relevant information. This surgery we are going, we're not likely to get it well done. Prognosis of the surgery, the outcome is likely going to be 60 or 70%. We should be able to say it. It's like a physiotherapist treating a CP patient, and you are telling the father, "Oh no, by 2 months' time the baby will walk." I mean, is that the truthful information? It's not. So we should be able to give them truthful information. So please, we just have only 30 minutes, 15 minutes. And I have 3 cases. So we're 90 in the group. I just want us to take 3 groups. Group 1, 2, 3. I have 3 case studies. So everybody just choose any group you want to remain. The case study 1 is about informed consent and autonomy. I said a patient refuses a recommended procedure. How will you deal with that? This is what I want you to tell me. Of course, we have discussed this when we were talking before. In the case 2, there is a conflict of interest and professional boundary. In this case, it's about accepting gifts from patients. A patient give you a gift of iPhone 17 Pro Max as a female, and a male patient giving you that, or vice versa, whatever. So, how do we take care of this conflict of interest and professional boundaries? And the last one is about resource allocation and justice. Talking about prioritizing patients with limited resources. So we're going to see the cases. The first case is about Mrs. BJ, a 65-year-old woman with chronic knee pain due to OA. And she has been visiting a physiotherapist. After thorough evaluation, the physiotherapist recommended a series of exercise, manual therapy, and the use of TENS to manage her pain and improve mobility. However, Mrs. BJ refuses to use TENS unit, expressing concerns about its safety and potential side effects. But she is willing to participate in the exercise and manual therapy, but adamantly decline TENS. So group 1 should tell us, how are you going to go about discussing the principle of, what do you call it? Principles of autonomy and informed consent in this case. So you tell us, highlight the principles of autonomy and informed consent in case number 1. So we would like you to discuss the ethical dilemma that you face there. Case study number 2 is conflict of interest and professional boundaries. I say is Mr. Ade, an elderly man, 72-year-old with chronic low back pain, of course, has been receiving physiotherapy for the past 3 months. Over time, he has developed a friendly relationship with his physiotherapist, Sarah. On several occasions, Mr. Ade has brought small gifts such as homemade cookies and a bottle of wine as a token of his appreciation for Sarah's care. Recently, he offered Sarah a valuable wristwatch. While Sarah is touched by Mr. Ade's generosity, she's concerned about the ethical implication of accepting such gifts. So I want us to discuss the dilemma in this case. So please, if you are from group 2, just tell yourself you're in group 2, and then you guys should be talking about it. And the last one is resource allocation. It's about Dr. Patel, who is a physiotherapist working in a community health clinic that serve a diverse population, including many patients from underserved and economically disadvantaged backgrounds. The clinic has limited resources, including shortage of physiotherapists, equipment, and treatment slots. Recently, the clinic has experienced an increase in patient demand, which has led to longer wait times and difficulty providing timely care. Dr. Patel faces the ethical dilemma of how to prioritize patients' treatment to ensure fair and equitable access to limited resources. So I want us to discuss this. So if you are for group 1, please just let me know by agreeing to discuss. Please, we are many, so just choose any group you want to belong to. Yes. We have only 10 minutes, please. Just 10 minutes. Can we make it snappy? Okay, just because of time, I think I should just go ahead and tell you what I have put down there for the situation. Excuse me, sorry. Okay. Oh, sorry. Sure. Okay. Sorry, are you with me? I don't know what is happening to my own board. The whole image is going off. Oh. Okay. Oh, I'm trying to get it closer, but it's not giving me the space. All right.
Hello? Hello?
Hello.
Yeah, Prof, I'll go for group 2.
Group 2. Okay, thank you. Let's hear. You want to
Yeah.
start? Yes, if nobody is yet for group 1, let's start with group 2. Go ahead.
Okay. From my own point of view, accepting a gift from a patient is not something that serious. To me, if there's nothing there's no string being attached there, because you have to maintain your professionalism.
Yes.
Not going beyond what you're supposed to do. But
Yes.
once you go beyond that, we are not asking the patient to get. It is very and totally wrong for someone to ask a patient for a gift. But if it actually comes directly from the patient's institution, I think it's more better to accept that gift, because once in a while, if you refuse, the patient might not even be happy because you never asked of it. He's the one that voluntarily, from his or her mind, that, oh, he really appreciates that he is going to give someone that even makes him to be able to ambulate or do whatever again. And once it's getting better, I think it's a source of appreciation. Once someone doesn't even actually ask from the patient that he should give me this or give me monetary reward or monetary raise or what. So that's my own point of view. Okay.
Yes, thank you very much. Who is with him in the group? Who wants to support or bring another idea in group 2? Yes. Does any person want to support the idea of group 2, or you want to tell us about what you feel? Yes, Deji, Itayo, go ahead.
Okay. So that's what I actually mean, because by the time I've seen a lot of patients like that, and I've seen a lot of PT as well, that they demand after a patient has been paid, there's no reason for anyone to ask anything from the patient, except on one condition. What you can ask for the patient is what the patient actually needs, not going beyond that. You just have to advise the patient. Once there's communication between you and the patient, you can just there's communication between you and the patient. If there's any other thing that the patient needs, there's no reason for you to ask for any other thing, except what you can just advise the patient that, okay, oh, sorry, sir, or sorry, ma, this is what actually you need. Maybe you can just go and purchase it somewhere and just bring it.
Yes, thank you very much. Do any other person has something else in the group? I will move to group 1. But I'm going to tell us some.
I'm going to support. Hello.
Feelings about the group 2. Yes, go ahead.
I'm in support of what Dr. Deji just said, because you see, by virtue of what we do daily as physiotherapists, if we are result-oriented and our patients get better, in some cases, they send in gifts to appreciate that which we have done outside of their medical bills that they paid. It's natural, it's human nature for people to express themselves in different forms. So if we take such gifts, I don't see anything wrong in that. But if the therapist is the one demanding for the gifts, that is when it is wrong. Thank you, sir.
Now let's look
Good
at the
evening,
situation.
sir. Please, can I speak up?
Good evening.
Let me speak from the lady's point of view.
Yes, please go ahead.
Good evening, Prof.
Good evening. I'm sorry, I'm trying to see my speaker so that I can recognize who is speaking. But Obolare, you can go ahead.
Okay, thank you so much, sir. Okay, so the case study states that this is a 72-year-old patient and the therapist in question is a female. Honestly, my practice, I know that even though he's an elderly man, sometimes some patients can be very funny. And talking about female-male relationships, so sometimes regardless of the fact that this is an elderly man, I try to keep the boundaries straight so that there is no room for unethical behavior. So sometimes it's not wrong to collect gifts, but we should be sensitive. If a lady senses that there's something more to the gift, there's nothing wrong with rejecting gifts. I have rejected gifts before, because if you receive the gifts, then you have to receive what follows after it. So if you receive the first gift and then you sense that it's going somewhere that it's not supposed to go, then there's nothing wrong with rejecting the gift. In fact, it will make the patient to respect you more, and to make you actually, it will make your relationship professional. Yes, the patient wants to appreciate you, but it keeps a professional relationship in place. Thank you.
Thank you very much. It means we just have to keep our professional boundaries, and then we should be very watchful. Now,
Good evening, Prof.
Issues. Okay.
May
Okay.
I
Just because
add
of time, I
something?
was trying to rush. Ezilo, go ahead.
Yes. Thank you, Prof. Good evening, everybody. I'm just want to add something to the last speaker. Well, there's something that we normally do. Basically, if in terms of gifts, okay, you want to collect gifts, and you are feeling somehow, most of the times, sometimes they'll tell us depending on the cadre of the physiotherapist, but most of the times what we do is to make sure that there are some other colleagues around. Okay, please come, Mr. Susu person is bringing gift to me based on Susu things. So get people also involved, get your superiors involved. So in that aspect now, you are not scared of how the gift would go, or whether there's something following the gifts. So you get some other people involved, so that at least when anything happens, someone will be able to speak up for you, or someone will know this is actually what this gift was meant for. Thank you.
Thank you very much, Dr. TJ Berry. Well, look at the ethical dilemmas I've highlighted here for us. So, number one is about conflict of interest. Accepting patient gifts can create a conflict of interest, potentially influencing the therapist's clinical judgment and compromising the quality of care provided. What I'm saying here is somebody bringing gifts to you, and then you keep collecting, you'll find out that by default, whenever the patient comes, you want to jump. You want to give the patient some treatment, you want to do more than what you do to others as the normal care. So you have to be very careful that the gift you are collecting does not create everything for conflict of interest. So that's number one. Number two is keeping to professional boundaries, like this lady just mentioned now. I said we must maintain professional boundaries because it is crucial in the therapeutic relationship. Accepting gifts, especially valuable ones, can blur these boundaries. And that's what she was saying, that one needs to be sensitive, especially coming from, the different sex partners. So it can lead to ethical and professional issues. So we need to be very, very sensitive to understanding where the line should be drawn. And of course, the third one is about the patient trust and autonomy. I said we should be able to balancing the patient's right to express gratitude while upholding professional integrity and ethical standards. Okay? So, of course, like our previous speakers have all mentioned, there's nothing wrong to collect. But at the same time, that gift should also be seen in a professional way, not also smearing the integrity of the professional who is receiving the gift. So I thank you very much, all those who have contributed to the group 2 issue. Can we go back to group 1? Yes, please. Group 1 is something that's quite interesting. We have seen it before. So who are those who want to talk about group 1? Fast, we just have like 5 minutes. They told me we are going to finish by 10. I thought I have a lot of time. So I didn't know we have exhausted the time before. Yes, please.
We extend 30, bro. We can still extend if possible.
So let me
extend 30.
Thank you. Thank you so much. So please, can we have somebody talking about the issues that comes up with the case in terms of autonomy and informed consent? We talked about a case of Mrs. BJ who is having chronic knee OA, and of course, the physiotherapist has given a recommendation for exercise, manual therapy, and TENS. But the patient, she does not want TENS, and then she's willing to do exercise, but she has declined use of TENS. So, what are the issues about autonomy and informed consent in this case? Yes.
Yes,
Can we have those in point to discuss quickly? It's a very good issue. I thought it's something that would call for more interaction. So, yes, please.
Can I contribute?
Yes, please, Chidi Ajiro, go ahead.
Okay, sir. So I think that for Mrs. BJ, since she already expressed some concerns, we can about the safety, you can let her understand how it works and the and let her know that it's considerably safe. You can also do a demo on your body in front of her so that she can be reassured that it's safe. And if she still insists that she doesn't want the TENS, if she still insists that she doesn't want the TENS, then we use other modalities to manage and treat her, ultrasound exercises and all of that to manage and treat her. That's my contribution.
Yes, the first thing is, I want you as a physiotherapist, how do you see and accept her autonomy to decline tests? Do you feel it's something worrisome to you, or do you feel she has the right to refuse tenants? So those are the issues. Now you have given her all the information, and that is why she's making an informed consent, because you told her about things, and then you told her things could cause this, can do that, and all that. And she does not want that irritation. And she said, no, she doesn't want tests. But of course, we could do some other exercise. So she has received alternative to tests. Okay? So now it's either you also going ahead to convince her that, okay, we're going to start gently, we're not going to allow irritation, and your body get adapted. So it's either you're trying to give her more information for her to see the more benefit of perhaps you're going to decline the things as she has declined, and then you talk about moving her ahead. Now, what other issues we could see in this case of Mrs. BG? Her willingness to participate in other treatment. What do we talk about that in terms of respect for autonomy? Group 1 members. While I'm thinking about waiting for somebody from Group 1, somebody posed an interesting question here in the group. It's asking it's a question from Dr. Moses Gata. My question is this. Let's say you are aware of a setup by an individual who is not a physiotherapist in your locality, running what clearly labeled physiotherapy clinic. Okay? You said, how would you as a professional physiotherapist reach the most appropriate way to say the lack of people that will have benefited from physiotherapy services, help save the face of physio? Now, what the person is talking about is he happened to know a quack clinic, because it's a clinic that obviously is not being run by professionals, but they are now also doing quackery of rendering physiotherapy services. He's asking, what should he do as a professional to go and stop that? I thought this is a well-known scenario, except if I'm not getting the point. Dr. Moses Egata, do you want to speak about that? Is that with us? Because this is just a clear case of...
Good evening, ma'am. I'm here. Yeah, you got the question right.
Okay. So now, this is just a case of quackery. The person is not a qualified professional to render the service of physiotherapist. So the first thing is to report the scenario to the board. The board has the Medical Rehabilitation Board, MRTB. There is an anti-quackery unit. The NSP could also be reached. And of course, these professional bodies can stamp and take that person to court and stop that services, so that you, at least one of the things you have done is the principle of non-maleficence. You have tried to stop any harm on those patients. So I think, and it is a professional thing to do. We must have to uphold to that. You can see how the board has been working tirelessly to see that we curb the issues of quackery in our Nigerian system. Thank you very much. Yes, are we having somebody to speak for the group 1 issue again?
Hello, sir.
Yes,
Good
thank you,
evening, everyone.
Mrs. Adedino. Yes, go ahead.
Okay. Yeah, okay. So I want to speak to this issue based on something I experienced in my clinic. We had a patient that had a condition that necessitated passive movements, but because of pain, she refused passive movements, and it was a case of an old case of stroke. So she'd had it for a while before she came to us. So she had developed she was developing contractures, she was developing stiffness, and she was in a lot of pain. So we tried using infrared and some other modalities, but we knew that to get her to even do active movement, we had to do passive movement, but the patient refused. So it was very painful for us in the clinic, seeing that there were things that we could have done to help her to recover better. But she had expressed her desire, and we had to just agree with her because we can't go against the will of any patient. So I wanted to speak to how sometimes painful it is when you see a patient that you can help with a particular treatment model, and then the patient refuses, and you see that that's the reason why the patient is not getting better, so to say. So we just have to accept the patient's decision. And well, what we did as a clinic was we would try to use other modalities to try to relieve her pain. And then we would wait for like a few sessions and then try to explain to the patient the benefits of passive movement. And she still refused. And we had to just leave it like that.
Yeah.
So that's just what I wanted to chip in, sir.
Yes, thank you very much. That's quite helpful because, you know, we keep talking about the principles of autonomy. The patient has a right to refuse a treatment. But of course, the painful aspect is when the professional recognizes that is the best treatment for this patient, but the patient is refusing. Now, I talked about this issue in the first time when I started my presentation, and I said, if you look at the Jehovah's Witness faith in Nigeria, they don't accept transfusion of blood. If a Jehovah's Witness patient, let's assume she's bleeding or during delivery and she requires transfusion, and the patient boldly refuse that she's not going to get transfused, and her PCV is already getting to less than 15%. As a doctor, what would you do? If we're talking about this principle of autonomy, what do we do here? Gentlemen and ladies, somebody should help us. What should we do?
Good evening, Prof.
My friend, sir. Good evening, sir.
Good evening, sir. I think, good evening, all.
You're welcome to join us, sir.
Based on the principle of autonomy that we have been talking about, and the knowledge that the interaction with the faith group you have talked about, the Jehovah's Witnesses, I think.
Unfortunately, Professor, sir, your network is not too strong. I don't know. Can others hear you properly? If others can hear, it's fine. We'll just move ahead. Can other colleagues hear the speaker?
Yes, we can hear him, sir.
We
Okay,
can
go
hear,
ahead, sir. Go
Okay,
ahead, sir.
thank you. I think so it won't be like so that it won't be like it's as if we are sounding like a broken record. I think you have said it from the beginning. that what the principle of autonomy is talking about is the patient has the right to accept or refuse after you have given your taking your informed consent. You have educated the patient on explain to the patient how the treatment will go and the pros and cons of the treatment, the adverse effect of the treatment, and the patient is understood you very well. So if the patient is refusing, like the Jehovah's Witnesses, we all know today that they have been winning in courts for people that go against their beliefs. They have been winning in court. So you have to give in to them, unless the two parties can agree on alternative. So because they are going into science into research to look out for various alternatives to receiving blood transfusion. So if there are alternatives, the aspect of the alternatives can be discussed and that will be given. But if there is none, because they too are ready to die instead of receiving the blood transfusion. So you have to agree with them based on their faith and allow them to have their way. Thank you.
Okay, good evening, sir. Hello.
Sorry, I did not get Dr. Moro very well, but at least the message was passed, and we appreciate. So I think at this juncture, I just want to call our attention that we should understand our primary role is that we need to protect the patient, and then everything we do is for the benefit of the patient. And that is the reason why I keep bringing up this scenario. Now, as a doctor, your primary job and your role is to save life. Now, a patient is refusing that you save a life. You have explained everything to the patient that, look, if you don't take this blood, you're going to die. And the patient said, yes, I'm ready to die. Now, you as a doctor, your own job is now, I must not let you die. So does the patient still have the right to say, no, I must die? Will you take that? How do you balance that autonomy with your own primary responsibility? I'm speaking to the issue of the speaker that said they had a patient in their place where passive movement was not possible due to pain, and then the patient was now deteriorating the more. So do we allow for that? So I think this is the issue I want us to discuss. Like for the Jehovah's Witness, the case like that was raised until it got to the federal government of Nigeria, the Supreme Court of Nigeria. And then the Supreme Court rules that the doctors must do their job of saving lives, whether the person in that faith accepts or not. It is either the person does not bring him or herself to the hospital for the life to be saved. But if the person comes to the hospital, the Supreme Court has ruled that the doctor must do everything that is possible to save the life of that individual. So for us as physiotherapists, we must also take in all available options. Like the patient you're talking about, if it means the anesthetist will come and give the patient a local anesthesia, for the pain to go down so that you'll be able to do your passive movement, that's one of the things we should do. Otherwise, we must have to do something that will benefit the patient. So that's it. So the last case we're going to be looking at, like I talked about, is the case of the issue of the community person who we talked about. He set up a clinic in a rural area, and then he does not have many physiotherapists. The clinic is becoming well known. Many patients are coming the more, and now he's finding it difficult. Because I want to take this an example. In Kano, we have a hospital that we call the Murtala Mohammed Specialist Hospital. In that hospital, because it's somewhat free, the state government is the one handling the, you may see about 100 patients in a day, and maybe there are only 10 physiotherapists. How do they manage these patients? You can imagine treating just only 3 or 4 patients in a day as a physiotherapist, how overwhelming that could be. Now you have 100 of patients to treat. Now, looking at the level of the staff, you don't have too many staff, your patients are coming the more, and now it means one patient will go in. After 20 minutes, other people can be shouting, oh, this guy has taken too much time, this one should come outside. Now, how do you control all those things? Is the issue that we're talking about resource allocation and justice. How do we prioritize our patients with the limited resources that we have in terms of staffing, in terms of equipment, and in terms of providing the best care? You can imagine if I have to treat 10 patients in a day, I'll just put in, okay, everybody enter on that, what do you call it, infrared or tunnel bath, and go, okay, we'll see you next week. That's not physiotherapy. Okay, so and that's not justice. I said here the dilemma we'll be facing has to do with this. How do we create a distributive justice? How to fairly allocate limited resources among the patients with varying needs and background. So assuming I have patients that more of NEO-A, and then I have only one maybe a sandbag for strengthening and all that. So it just depends on what I have that I will have to allocate fairly to the patient. And of course, we have to think about balancing the individual patient needs and preferences with the necessity of prioritizing treatment based on urgency and potential benefit. And the last one is professional responsibility. I think we should be able to make decisions based on clinical judgment, ethical principles, rather than personal biases or external pressures. External pressures such as when the patient begins to shout, this guy has stayed in the cubicle for 30 minutes. We're all waiting outside. You know how rowdy such type of clinic can be. So please, we should try as much as possible to act professionally based on the limited resources that we have. The night is drawing closer. I'm trying to rush these. So I remember we talked about keeping professional boundaries. I said, what are these boundaries? Professional boundaries are the spaces between professional's power and the client's vulnerability. That is what is within your own power, and then what the client's vulnerability might be. These boundaries ensure a safe and therapeutic connection between the therapist and the patient. Maintaining professional boundaries is crucial for protecting both the patient and the therapy, because ensuring a relationship based on trust, respect, and ethical behaviors. If you have professional boundary, number one, clear boundaries can help you establish and maintain trust and respect in the healthcare relationship, because there must be clear boundaries. There are things you don't go towards. This is not it. The patient don't go there. You as a therapist, you don't go there. Of course, these boundaries protect patients from exploitation and harm. Of course, you don't use because you are the therapist to exploit the patient or you harm the patient. Of course, we should know that the boundaries can ensure that the healthcare provider acts in accordance with ethical guidelines and professional standards. Of course, lastly, your ethical or professional boundary help, it creates that clarity that helps both patient and provider understand their roles and expectations. Everybody knows where he or her belongs. So I said there are some key professional boundaries that we must know. Number one, physical boundaries. Physical boundary involving maintaining appropriate physical distance and avoiding unnecessary touch. I talked about a male physiotherapist coming to want to access a female's back. You don't go there with the patient alone in the cubicle. Even though if you are the expert, you must try to invite another female physiotherapist to stand into the cubicle so that that patient can be feeling comfortable and safe. In fact, at a point, you can ask female therapist, evaluate the patient and tell me about the patient, you know? And of course, physical boundaries means you must only treat where, because I want to expose the patient back. I should not take off the whole clothes. You can pull up the clothes above and cover your chest. So physical boundaries should be there. Need for touch should only come when you are palpating or you're trying to do manipulation. Of course, we should also understand where the emotional boundaries are. Emotional boundaries involve maintaining a professional distance and not becoming overly involved in the patient's personal life. Okay, so we must not go where it's not our boundaries. Of course, we talked about the power dynamics. I say healthcare professionals inherently hold a position of power because, like I said, you are the doctor. The patient see you as the alpha and omega, and therefore you don't use that position to now, unnecessarily exploit your patient. It is essential to use this power responsibly, avoiding any action that was perceived as coercive or manipulative. At the same time, we should also know that there's a dual relationship. That is, it can occur when a healthcare professional has another significant relationship with the patient outside the clinical setting. For instance, the patient is also your neighbor. The patient is also maybe a family member. So there's a dual relationship, and you must understand that you, as the therapist, there is a dual role you have to play, and then you have to play safe in those roles. Of course, there should be financial boundaries. Talking about accepting significant gift of financial incentive from patients, which can blur many of these boundaries and create conflict of interest. So these are the issues we're talking about. We should be careful about. So what are the strategies you can use to maintain an appropriate boundary? Number one, you should set clear communication. When you start treating your patient, you should explain to your patient regarding availability and nature of the therapeutic relationship. Please, I'm here as a therapist. My role is to treat you. Please, we don't do this, we don't do that here. You let them know. You should use professional language. Avoid using all this common slang in the town and city. Hey, boy, how far? All those things that can make you feel as if we are just friends here. No, there must be professional language that you use. Of course, you want to educate your patient on the importance of that boundary to help them understand that you're not being arrogant or you're not being somehow, that this is due to your professional and certain practices and policies, and therefore cannot relate with them otherwise. In maintaining professionalism, you must dress appropriately. You must wear professional attire that reflects professional nature of your health setting, healthcare setting. And of course, you must adhere to ethical guidelines. We will have it in the NSP guideline, the MRTB guideline. So please, let's avail ourselves all these guidelines so that this guideline can provide a framework on how to maintain appropriate boundaries. I say you should try as much as possible, avoid dual relationship. People that are not your family members, don't engage on a fiancé and fiancé, whatever relationship, and then professional role. It will overlap. You will know which one is which. And so we should be able to manage personal disclosure. We should be able to limit personal information. Your patient should not know everything about you. You should be cautious about sharing personal information with patients. While some personal disclosure can build rapport, excessive sharing can blow the boundaries. And of course, the focus should be on the patient. Keep focus of the interaction of patient's need and concern. Whatever you're doing, redirect the conversation that veer into personal territory back to the patient's care. So this is what we want. And they handle gifts and financial boundaries with care. Follow policies. Some departments, some hospitals, they have their policies. There was a place I worked in South Africa. Even as a staff member cannot give me anything that is worth 10,000 naira. They call it 100 rands. So I cannot get a gift from even a staff, not to talk about a patient. So that the policy is there. So you should be able to adhere to such policies regarding accepting gifts. But most of us in Nigeria, we don't have any policy. And that's why those things become a problem. I say if a gift is offered, politely decline or refer to clinic's policy on gift acceptance. Some of us have said, okay, tell the person to go give it to the HOD or the head of unit has to know that this is how we do, so that the person will know that, okay, it's not about you. All right. And of course, I said we should be able to suggest alternative ways for patients to express their gratitude. Or if you want to appreciate me, I think you should buy a water can for the department, or you should buy a TV for the department. I mean, let it be for others, not for you. Suggest other way, okay? So those are some ways we can handle those. Because lightly, I talked about the patient right. I said the patient has a right to informed consent, privacy, and equitable treatment. Ensuring patient has right to ensure respect for his own dignity and privacy. He has a right to protect patient confidentiality and personal information. It's his right for you to protect it. And of course, the patient also has the right to come and share his own grievances and concerns about the hospital or about the therapy. And of course, mechanism for patients to voice their concern and sickness must be made around. So lastly, we'll just look at the ethical decision framework. If there is a problem, what do you do to solve the problem? I said there are steps. Number one is identify the ethical issue. What is the problem that happened? You should gather relevant information. Second one, now consider the ethical principles and value. Which one was breached in the problem? Then explore options and consequences. Look at all the options that are available in trying to solve this one and the consequences. Then you make a decision and take that decision. When you take it, you go back and evaluate the outcome, and then this is how you can use to apply this framework for any real life scenarios. So we've talked about our group activity. We have done them. We don't have any more time. It's already well, ladies and gentlemen, the several key takeaways I want us to know today is that whatever we do, it should be about patient-centered care. We should be able to ensure informed consent and honor patient choices. We should be able to balance benefit and risk. We should be able to give equity and justice. We should maintain our professional boundaries. And of course, we should know that continuous education is necessary. In conclusion, the ethical practice of physiotherapy is not just about adhering to rules and regulations, but about embodying a compassionate, respectful, and principled approach to patient care. I say by integrating these ethical principles into our daily practice, we can enhance the quality of care we provide and contribute to the trust and respect that form the foundation of therapeutic alliance. I thank you all for being with me till this 10:30 p.m. If there are any few questions and answers, so let's interact. Thank you very much. Have a wonderful good evening.
Thank you, Prof.
Yes, any questions?
Can we start?
Yes,
Yes.
Dr. Deji, your hand is up. Yes.
Good evening, sir. There is a question from my side.
Okay, go ahead.
Sir, this patient autonomy. I have a patient. Patient has a road traffic accident, and he had an ORIF.
Yes.
In fact, for more than 10 weeks, the bones are well aligned and everything. I did my assessment, and there's no pain. There's nothing that is limiting him from ambulation, like normal ambulation. Although he uses crutches. So when I did my assessment, the power is okay and everything. So I asked him, I told him, okay, these are your options. You can be able to work, you can do this. I encouraged him. He was like, no, somebody told him not to put weight on this, on the leg, on all these things. I said, no. Based on what I have found out, you can work with or without the assistive device. But because you are just coming, we'll work you gradually. Maybe we'll start reducing the working aid and so on and so forth. So we reduced the working aid. He worked with one crutches. In fact, before the end of the session, we collected both crutches and he worked well. It was very okay. Unfortunately, he went home and by his next session he's coming, he's not putting weight on the limb again. What happened that he went back home and somebody still told him that he shouldn't be putting weight on the leg, blah, 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 and all this. So in this scenario now, looking at patient autonomy, what can we do about it?
Yeah, Dr. Itayo, I think we got your point clearly before your voice started seizing off. I think you see we're going to face with many kind of problems like that with some patients. Imagine that as professional, somebody back home whom the patient trusted and believed. For instance, the pastor, the imams. And I've had a patient who said the imam said he should never accept to get any medication via IM injection. The day he does that, his fracture will never heal again. You understand? So, but all those things are myths. It will take you a lot of time to educate, and re-educate the patient until you're able to take it away from their mindset. It's something that has to do with their mindset, perception, and of course, and beliefs from where they are coming from. So you can't do it overnight, okay? Even though they have an autonomy, but you should also recognize that you also have a professional responsibility to do what is right. So please, let's always not mix it up. Like I said, the Supreme Court has ruled that as a professional, as long as that's the best interest of the patient, we need to do it in a way that will help the patient. So that is it. A question is dropped in the chat box by Dr. Ajiro. He talked about, as a professional, how do you treat a family member? We're allowed to treat our family members like me, my wife, or my wife to treat me, or me treating my child? Is it allowed? Is it acceptable? If it's acceptable, how do we do that? Dr. Aita, please drop your hand so that we don't see as if you are the one raising your hands again. Yes. So who wants to respond to that, please? Are we expected to treat our wives or ourselves? Yes, please.
Hello?
Yes, go ahead.
Hello? Yeah.
We can
To
hear
me,
you.
I think it's not actually appropriate. I think it is much more better for you to get your own professional colleagues to do that for you. Because there's
Why?
a lot of things.
Yes.
Okay, good. There's a lot of things that is involved there. Let's happen it happens to be someone's wife. It's as good as if you're teaching your wife how to drive a car. There's no way you're not going to fight when it involves giving her instructions on what to do on the wheel. It's as good as that when it happens to be your wife as well. It is not better. Your wife is going to respect your professional colleague than you that wants to treat her. Yeah, that's just it.
Yes.
That's my
Actually, the reason is this. There is going to be a conflict of interest. Okay, sometimes it's either because your wife had done something wrong to you, you might not even give her the attention that is needed, and sometimes you can be over careful with her because she's your wife. You want to do this very well, so that is the reason why you need a second party outside to handle it in a more professional way. You may you may not follow all professional standards when it comes to you and your family. And that is the reason why we should not treat our families ourselves. Yes. So somebody talked about they want the slide. We're gonna give the slide. The organizers are going to share the slide. Yes.
I have a question.
Okay, go ahead.
I have a question, sir.
Yes, please go ahead.
Okay. Thank you, sir, for the lecture. It was really, really nice. But my concern now is when a patient, okay, it's like a question, during a round,
Yes.
and a
Yes.
patient asks you that you should let your male colleagues leave the cubicle for before treatment. Is that allowed? Maybe a patient says, okay, I cannot be treated, or maybe allowed to be assessed. Let all your male colleagues, especially for some of us that are in the um, service of training interns or training some other younger physiotherapists, and they say that all those
Yes.
your trainees should go for you to be able to
Yes.
do something. So in that scenario, would you let them go, tell all the males to leave, since they are also on training as well,
Yes.
working in a tertiary
Yes.
institution? Okay. Then the
Yeah.
second
You see,
one,
we talked about. Okay. Okay. There are two questions. Go ahead.
okay. The second one
Continue.
is could there be a time when one has to be conservative with the truth, or with the whole truth? Let me just use that word, conservative about it. Because I have a situation. I had a situation where I worked before, when one elderly woman fell, was playing with the grandchild, so fell and was brought to the orthopedic ward. So the X-ray came out. She obviously had fracture. But
Yeah.
when I came to assess, I saw the anxiety. I saw how she really wanted to know, did the bone break? That was actually the language. So when I saw it, so I tried to play along with words, okay?
Yes.
And I was also reassuring her and played along with words. So immediately I left, and we're about to prepare for the reduction. Immediately I left, the doctor I was working with came, and while they were interacting, we said, "Doctor, did he break?" The doctor said, "Yes, now he broke. So see the X-ray. He broke here, and we are going to enter the theater. We'll do this, we'll do that, we'll do this." So immediately the doctor didn't even get up to 2 poles or 1 pole. The woman died.
Hey.
Died. Before he could, they started calling, "Doc, doc, come." So we started resuscitation. The woman died. So I saw
Ah.
it that she was really, really interested in knowing, did he break? Did he not break? What kind of situation am I going to put my people if it's actually broken? And the theater, and you work in some, there are also cultural variations or cultural outplay in some situations, where if they know a particular thing, it affects them psychologically, it affects even recovery. And that's why sometimes they will tell us to always ask, when you are doing your assessment, the cultural beliefs. I've worked in a place that they will tell you, if you receive any transfusion, you will die. And probably it may have a way to play, or a way that it happens, or maybe it occurs in some of those patients, why they believe strongly in, if you have a stroke and you receive transfusion, you die. So what I'm trying to say here now is, could there be a time where one will now be, maybe based on your assessment, be conservative with the truth? Then the final
Yes.
thing, but
Thank you
this one
very
is not
much.
a question. The final thing is not a question, but I just wanted to say we should also emphasize on our own documentation. Sometimes patients reject, okay, patients has the autonomy, yes, but once you respect the autonomy, yes, but once you are done with this, always make sure that you document appropriately, so that tomorrow, if one picks up the documentation and say, "Oh, why was the right thing not done for so patient?" one will see, okay, it is because of patient did this, patient declined, patient. So you don't go just documenting what you did and not documenting the appropriate thing you should have done when the patient declined treatment. Thank you.
Well, thank you very much. much. At least we got your point very, very clearly. And it is worthy to note that most of this information are picked from our discussion today. And that shows how clearly that we've been following. Thank you very much. Dr. Chidebere, I think the first question you were talking about autonomy of a patient. And of course, you as being the senior therapist, you have interns and other juniors you want to talk about, or you want to do what round. And the patient is saying, your interns and others have to go out for you have to be able to accept your treatment. Well, it's something you could explain to the patient, and after all explanation and the patient still refuses, then you have to respect that her right for refusing to want other people to be there for the treatment. So please, you need to accept that, and then you move on to other patients with your students or students or interns, whatever the case may be. Sometimes it could even be another physiotherapist, a senior colleague. You go into the place and she will say, this person, I spoke with him the other day, he was not doing this and that. Please, if you need to treat me, he has to leave this place. What do? You have to go. In fact, I've seen in a country where a patient told one of our colleagues that, look, I just don't like you. Why? He said, no, I don't know, but I don't like you. My spirit don't like you, so you have to leave. So please, we need to respect that as a autonomy of a patient. Secondly, is concerning how you pass information to your patient. And that's why we need to be very, very sensitive. Of course, we talked about the principle of veracity, truthfulness and honesty. Of course, it's not that you're telling her lies, but you must find a subtle way. Like you said, you are very sensitive to the patient's emotions. That when she brought in the patient, her prayer is that I hope this thing has not fractured. I hope, So, but you needed to find a way of passing the information. You're passing the information in a subtle way that she will understand, and over time, she will get to see. By the time we do the casting and everything, and the thing is now back, then we can open up to her. But your surgeon who was carefree, we don't say he's careless, but he was carefree and did not recognize the emotion of the woman and just hits the information like that. It's like, when you come and you say, somebody has died, but you knew you're coming to the family. Maybe the wife or husband, and you know how sensitive they are. You're not just coming to hit the news like that. You're coming for the theater, and the patient they took to the theater passed away on the table. You're not coming to theater. The patient that died, no. The patient was still struggling. We're trying to resuscitate the patient. So you're passing the information gradually. So it's not as if you're telling lies. You're not telling lies. So, but we just need to be very vigilant when we are making all sorts type of information. And lastly, I think the last point you made was about, what was it about? I think I skipped that point.
Documentation.
Yes, documentation, very, very
appropriate
vital.
documentation.
Yes, very, very vital. I think we had a course we will do maybe early next year, which has about documentation, discharge, and continuity of treatment. So if you don't have a good documentation, number one, you are liable to many charges. You may not have anything to defend yourself. So please let's get those things properly done. Dr. Deji, you are still raising your hand. This is 11 o'clock. People want to go and
Just
sleep.
give me now. Can you just give me 2 minutes? I won't take much of our time. Just a little contribution, please.
Yes, go ahead, sir.
When you are talking about the issue of patient PT reliability, I think we have to be extraordinarily cautious when it comes to that. Because I've been indebted sometimes ago when I stood for some patients that they are going to pay because they have been sincere with their payment plan and they have been doing that. All of a sudden, they vanish into thin air. I was the one when the external auditor when it comes into audit department. There's no excuse they can give as at that particular time. I have to pay that money out because the patient, when they are okay, they decided not to come again. And I happen to be the one to bear the brunt of the cost.
Exactly.
So everybody needs to be cautious when it comes to that. When you think your
Well,
patient
well,
is
that's
when you
right.
think your patient is reliable, it might not be reliable. So we have to be extraordinarily careful about patient on this reliability. Thank you, sir.
Thank you so much. Well, we really appreciate you. And of course, somebody is also, Chooks is sending us that for those Jehovah Witness I mentioned, we should stop saying we want to give blood transfusion. We should tell them we want to put some platelets instead of fluid. I think so. Those are some ways to go about it. We should also look at that in terms of our own physiotherapy institution. So I thank everybody very, very well. I'm so happy that we all interacted. It's late night, but you can see how many people are still active. So I appreciate us for coming for the program. I look forward to meeting us again in another course. I thank you very much and have a wonderful night, Rice. Thank you so much.
Thank you, Prof. Good night.
Thank you, Prof. Good night.
Prof. Good night.
Thank you, Prof.
Thank
Good night.
you.
Thank you, Prof. Good night.
Thank you.
Good night, sir.
Thank
Good
you,
night.
Prof.
Thank you so much, sir.
Thank you so much, sir. You did a very nice job. We are grateful.
Thank you so much. Good night.